Hey, esteemed colleagues, this is David and Christopher coming at you. We're trying to do a education committee initiative on trauma care. I'm going to be touching on primary assessment. As a part of the education committee, we're taking monthly initiatives. As you know, from last month it was the airway checklist. Prior to that, or what we were doing prior to that.
Secondary piggybacks.
Yep. Safe medication administration. We're going to be picking whether it's high acuity, low occurrence procedures and policies kind of things, and we're going to be touching on them, trying to bring them out to the rest of the department and be involving our staff in more informed decision making. So the one we're touching on this month is trauma and primary assessment. This is one of a couple options that we're going to have to get the information out. We'll touch on that at the end, the other options at the end. But when it comes to trauma care, we'll start with what it means for trauma at UVM. Obviously, we have two different activations, and they get you different resources and people. In the breakdown of green and red traumas, you also have pediatrics and adult, and you can have some special considerations when it comes to OB. The big thing, a green is going to be mechanism, a couple long bone fractures, a non-isolated head injury with another bone, another fracture or injury. Some things that make a green trauma go red is its mechanism with accompanying vital signs, whether it's a motor vehicle accident, long bone fracture, they're receiving blood en route, they have a blood pressure under 90 at any point, altered mental status, or if we have a patient that's getting flown in from the scene with no vitals that are relayed to the staff. Obviously that gets a lot of people. When the big thing about red traumas is that we have obviously 3 nurses, 2 techs, the chief resident and the primary nurse running it, meaning the documenter. They are going to be they should be the only people talking in the room. All communication should go through them. Try to keep low stimulus environment in the room, and they can direct the appropriate care to who is involved. One nurse is usually attached with one of the residents to do procedures. Another nurse is managing meds if pharmacy is not available, and then helping out with the Belmont and blood infusion with one of the techs and obtaining access. And another tech is helping out with monitor life pack, things of that nature. The other thing is that sometimes we have trauma patients that come in from outside hospitals that don't necessarily meet activation criteria, or they've had their entire trauma workup at an outside facility. So the third designation is just a trauma consult. If you've had a patient come in that's a isolated head injury and neurosurgeon says, I need a trauma consult, it's essentially the ACS team coming down saying, doing their primary, secondary, and eventually a tertiary survey and making sure that we don't have any missing injuries from the distracting injury in the head. Over the last year, we've been averaging, our numbers go up. In the summer months, we average 70 to 90, sometimes pushing 100 trauma activations in the summer and 50 to 70 in the winter. Yeah.
So the transition from EMS has been something that we've put a lot of focus into over the past few years. So when we're setting up the room before the patient arrives, we should be doing a pre-huddle led by either the chief resident or the primary nurse to identify everyone's names and what their roles are, and any updated information about the patient. From there, the EMS crew will roll in with the patient, and the first question they're going to get asked is this patient stable or unstable? And that's a pretty important designation to be made as soon as they roll through the door. If they are unstable, what you're going to do is take the patient, move them over to this EMS stretcher, to the ED stretcher, and start working on them ASAP while also listening for a report. However, if the patient is stable, their vital signs have stabilized, or even if they're getting blood, but they are stable and they have a good airway, at that time, the whole room should stay quiet while the patient is still on the EMS stretcher, and EMS will give an entire report of what happened. It's important to remember that we should ask the EMS folks to speak loudly, as they are not often used to giving reports to a large crowd. And please save all of your questions until the end. And if they don't know a specific answer to a question that you're asking, just acknowledge that and kind of move on. Don't make them feel bad. Sometimes they can kind of get grilled by the trauma team. And a lot of these folks, especially for our transfers, don't have all the answers because they weren't the initial transporting service. So that's an important thing to remember. We'll always ask for their highest heart rate and their lowest blood pressure. Those are going to be used in our indications for shock and how stable the patient is. And then the stable versus unstable transport. Most of the patients that come over as transfers are rather stable. The outside hospitals do their best to stabilize the patients prior to treating, because the place to stabilize a patient isn't in the back of an ambulance, it's in a resuscitation bay. That being said, we all know that sometimes we get these train wrecks of patients, and it is what it is. So always important to make sure that you know how many units of blood or crystalloid that they received en route.
And David, you can touch on this a little bit more with your EMS experience, but the important thing also is that none of us in the hospital were on scene. So we should be listening to our colleagues. They know exactly what happened, whether it's what the vehicle looks like. They may have some more information if there's other patients coming in. Really shut your mouth and listen to them, because they are the experts of the first 10, 15, 20 minutes of this patient's case. And to just touch on the lowest blood pressure for a patient, if they have one single blood pressure under 90 systolic at any point, it doubles their mortality and morbidity in a trauma patient. So really important to have that number and be aware of it, and be aware of their potential bleeding risk. So the primary survey, we all know, it consists of uncontrolled hemorrhage, airway with cervical spine protection, breathing, circulation, disability, and exposure. If you know your alphabet, you can remember the primary survey. The big catch-all is that you cannot advance from uncontrolled hemorrhage to airway and any of the other ones if you have not fixed a threat to life. The important thing here is you need every part of the survey, every letter of the survey is a systematic approach to identify threats to life and appropriately intervene with reassessment. Once you feel that if they don't have any uncontrolled hemorrhage from across the room assessment, you can advance to airway. We'll touch on this obviously a bit more, but if their airway is not protected, you can't move on to breathing and circulation. I know sometimes our ACS residents like to do that, or they like to move simultaneously. We have a big bunch of resources in a big department where our ED attending can focus on the airway while the ACS resident continues on with the primary assessment. That's okay, but this is ATC and TNCC are meant to be used at any facility and used by a one provider trauma assessment.
So uncontrolled hemorrhage, most times these are one of the easiest things to assess and fix. Is someone spurting blood while they're still on the EMS stretcher? Or do you notice massive pools of blood around anywhere on the patient? The across the room assessment should almost, I like to call it almost the pediatric airway. The pediatric assessment triangle. Like, how sick is this patient and how can I fix it the quickest? So it's uncontrolled hemorrhage, then the ABCs. So focus on the hemorrhage. And what do we have? We've got tourniquets, both the CAT tourniquets and the auto cuff. We have hemostatic gauze, pressure bandages. We have pelvic binders for if we believe that they're bleeding into their pelvic cavity. And then junctional devices for all of our kind of other places that we can't really wrap with a tourniquet or put a binder on. This is super important, right? Because this is how they're going to die the quickest. So focus on the hemorrhage and then move on to your ABCs.
With airway, the best thing to ask is when you advance past uncontrolled hemorrhage, if you just ask them what's their name and basic quick assessment. If they're able to respond and speak to you, their airway is likely clear. So you're assessing for patency. If they're altered mental status or they're not able to protect their airway, you want to do in the mouth inspection. You're looking for things that shouldn't be there. Broken teeth, secretions, blood, vomitus, any of that. If you're able to get those things out, suction them out, you want to reassess after that intervention and see if their airway has become patent now. If not, then we need to work on jaw thrust, put an OPA or an NPA in, and then prepare for intubation. And we prepare for intubation before we move on to breathing and circulation. When we intubate, obviously breathing kind of is simultaneous with that. But again, you cannot advance the breathing circulation if the airway is not secure. And the airway can be secured with a definitive airway, whether that's a surgical airway or endotracheal tube, or it can be the OPA, the iGel, things like that. But the important part is that if they're not protecting their airway, that we really want them to get the definitive airway, a cuffed tube below the cords. Cervical spine protection, the C-spine goes with airway. So putting patients in collars, especially if they have a fall, a mechanism that could be potentially have a cervical injury. And kind of post-intubation needs, this goes simultaneous, hand in hand with our airway checklist. We want to have some form of sedation, analgesia plan afterwards, getting X-ray, Foley, NG to decompress the stomach after bagging them. It also goes with kind of peri-intubation needs, getting these patients oxygenated up, have apneic oxygenation in so we can get their reserves up so we can potentially, if we are unable to get that first pass, then they have some oxygen reserve ready to go. Yeah.
So for breathing, we always want to look at the chest rise, make sure that the patient has equal and bilateral chest rise. We want to make sure that they've got a pretty normal rate. And I think oftentimes they come in a little tachypnic, whether that's from pain or from the physiologic shock. It's important to just note that within those first 5 minutes, get a good baseline of their respiratory drive. If we'll listen to lung sounds, if we've got decreased lung sounds on one side and signs of shock, we have to be thinking about possible pneumothorax or tension pneumothorax. Based on all of our protocols, the first thing that should be done is needle decompression, and we have 2 14-gauge angiocats located in the cart in 9 and 10, taped to the doors. That should be easy to access. From there, that's not a definitive treatment. That's a good bridge to either a finger thoracostomy or a full chest tube, which kind of should be our definitive treatment in the ER. So keeping an eye out for that. If the patient is already intubated and we're not hearing any lung sounds on the left side especially, we should get another x-ray to confirm placement. Oftentimes these can have a right mainstem intubation, and that can kind of lead to pressure injuries down the road, especially if the patient's being vented and not just bagged. And that's something that we need to kind of recognize quickly. Luckily, all of our trauma patients will be receiving a chest and a pelvic x-ray, so they should be there soon after intubation anyway. If they are paralyzed and on the vent, and all of a sudden you notice that some alarms are going off, or there's a decrease in the amount of compliance that the patient has, or it's getting more difficult to vent, or you hear a high pressure alarm or a low pressure alarm, we have a mnemonic called DOPE. And that's kind of how we should start assessing what's going on with the airway. So the D is for dislodgement. So did the tube come out or get misplaced when we move the patient from our bed to the scanner or the scanner back? Is there any obstruction? Is there blood in the tube? Is there any secretions? Oftentimes these folks do require some deep suctioning, and that's a pretty simple fix for this. Did the patient develop a pneumothorax? Did they have a small one, and then once we intubated them and gave them positive pressure, did we make that any worse? And then E is for equipment. So is there something wrong with our equipment? Did the tubing get disconnected from the ET tube? Did we forget to connect it to oxygen instead of just the air? So kind of run through that DOPE mnemonic. Again, that's dislodgement, obstruction, pneumothorax, and equipment. And while you're doing this, you should also be bagging the patient. That comes first. That comes as soon as you hear these alarms going off, start bagging the patient, and then assess your DOP and E. And stand by for the second part of our video.